feel very short, per usual. Feel very short? No, am very short. Let's be real here. Let's be real. All right, thank you all for being here. We appreciate your time. We appreciate you coming out. We cannot do this without all of you. Hopefully we'll have some other families show up in the near future. But for now, you guys are the cool ones. So we'll go ahead and get started. So again, I am Alexa Tinsley. I'm the Director of Programs for Jett Foundation. That lady back there taking a picture is Julie LeClaire. She is our Community Program Coordinator. Got to give a shout out to her because she is very instrumental in making all of these workshops possible. So we are here in Columbia today. It is our last workshop of the year, so we're very excited to be here. This is our agenda. Oh, I think it's my phone. We're very excited to be here today. This is kind of a fluid agenda, so if talks go shorter or longer, we'll take breaks as we go, but this is the base of the day, so you connected and are welcome at 10. We will have our intro now. Non-invasive ventilation will be at 11. Dealing with school-related issues, 11:45. We will break at 12:30 for about 15 minutes. Then we'll have an update on DMD gene therapy, a parent and individual perspective at 1:30. Lunch break at 2:15. Pharma presentations at 2:45, and then we will do our pharma meet and greet at 3:15. See how that goes, because we kind of end up meeting and greeting at lunch most of the time. But if you need that time, it's definitely there for you, and then we will wrap up the day. So Jett Foundation, if you don't already know, which I feel most of you here do, was founded by Christine McSherry. In 2001, she named Jett Foundation after her son, Jett, who was diagnosed at 5. So that is where we started. And today we are, our mission is to empower people and families impacted by Duchenne muscular dystrophy throughout the development of transformative programming, educational opportunities, and ongoing support for every stage of a Duchenne journey. So we're really, we really focus on direct service programming, helping families now and meeting them where they're at now. But before we get started into our programs, I like to do a little intro icebreaker because I feel like it's important, especially in smaller groups like this. Like, let's figure out who everybody is. So I'd love if you could give your name, where you're from, so, you know, city and state, especially those who are in Missouri, so you know where those connections are. And then your favorite animal we'll do this time. So I will start with Dr. Dwan. So first on our list is Camp Promise. So our Camp Promise program was actually born out of a year that MDA was not operating due to swine flu. And one of the things that we are really about here at Jett Foundation is filling gaps. So we were able to make it happen this year, or that year I think it was 2008, 2009 maybe, and Camp Promise was born. So our first Camp Promise was, I believe, Camp Promise East, and we have now grown to 5 locations and are looking to expand in 2024 as well. Not yet. We'll get there, I promise. We are looking at expanding in 2025 to a central location. But we do have 2 types of programming at this point in time. We have a week-long program, and that is for ages 6 to no upper age limit. So that's one of the best things, in my opinion, about Camp Promise is that there is no age limit, because MDA ages out, and that's a very sad thing to see. But everybody is welcome at Camp Promise. And one of the things is, although we are an organization that primarily works with individuals and families impacted by Duchenne, Camp Promise is for all neuromuscular diseases, not just Duchenne. We also have our Camp Promise retreats. Those are 18 plus only. So all 18 plus community, our locations there are currently Arizona and Ohio. Our week-longs are Washington, Pennsylvania, and Colorado. And then we also do have Camp Promise Connect. That is it'll be a weekend program, so that is for those who aren't ready to go to camp, who aren't able to go to camp, or just want to do the virtual programming. So our virtual programming will still stay in place. Here are some pictures. So we've done hot air balloon rides, we've done kayaking, biking. So it really is a place for all of our campers, and we make sure that every activity is accessible for everybody. So it's a really, really special place to be. If you go to Rockies, though, we won't have a hot air balloon because we're not allowed. But we do our best to try to give the same experiences across all of our camps as well, as much as possible. Our Jett Giving Fund is another one of our core programs. We have our Accessible Vehicle Fund, which is open now. It opened on October 30th and will close on December 15th. And that is Jett Foundation helping families obtain safe, accessible transportation. Families raise half or more of the funds that are needed for that vehicle, and Jett Foundation provides the remaining funds and purchase the vehicle outright. There aren't any loans, so you have that van hopefully for many, many years. We do make sure that it is a new or lightly used vehicle in good condition that works for your family. So like I said, that is a once per year application. It did open on October 30th and will close December 15th. Decisions will be made January 22nd. Our emergency fund is actually a rolling application, but you can be awarded once per year. So these are grants for families that are facing emergency situations. This was actually born out of COVID, but we realized emergencies don't just happen during COVID. So we wanted to make sure that we were able to sustain this program. So our most common emergency situations are for mortgage, rent, utilities, food insecurity, and there are also other things that we assist with as well. But like I said, that is rolling. It can be an application at any time, but it is a once per year award. However, say you got awarded in December, you could apply again in January. So it's not 12 months after you've been awarded, but within that year. And then very newly opened is our Equipment Assistance Fund. So you'll also hear me say that we do our best not to duplicate efforts, and we understand that there are other organizations that offer equipment assistance as well. But what we were finding is people were still coming to us asking for equipment assistance, and that there just aren't enough resources to help everybody in that space. So we did open that on September 26th. It will be, again, a rolling but once per year application, and it's a max grant currently of $2,500. So this is a family that we awarded last year, Darnita and Lido. So their smiles just say it all. This is what our program's all about, is truly helping families. We also have our community webinar series, which was actually born out of our family workshops during COVID. But we understand the need for education and knowledge in the community and accessibly. So we do have one per month at least on topics such as care in DMD. We just had one on physical education, respiratory management, social security. So we take feedback from the community, and we make sure that we're putting those into webinars for the community. And since we are a national organization, making sure that we can reach everybody is very important. Our community ambassadors, we have two of them here today, Susan and Mary, so thank you. So these are our people within the community. We currently have 35 ambassadors over 19 states, and these are people to connect with people in the community. So say I have someone from Missouri, I know who to go to. Or say I have someone from Iowa, I know who to go to help connect them with resources. But also, if there's a family that, is newly diagnosed, I can connect them with another family so they don't feel alone. So, they're here to help with resources assistance, emotional support, advocating, as Susan said, Mary said, like, they're advocates, and they're big advocates, and that's really important in this community, which we all know. Family support groups. So we currently, we should have changed this slide, because speaking of carriers, we actually so we have two resource specialists currently. We have Jessica Campbell, who is a mom based out of North Carolina, who was an ambassador previously. And then we also have Trina Stelly, who is based out of Louisiana. She had a son pass away from Duchenne, and she also has a manifesting daughter who's a manifesting carrier and started showing symptoms at age 5. So, and she also herself has symptoms and is She is a huge advocate for this community. So she is on our team, and we actually do have carrier conversations every month. So manifesting or otherwise, going into that community to talk about, what's going on, what you need support with. But Porch Night is also another one of our support groups, and that is bi-weekly, virtually. We also did have 3 in person, and we'll have 4 in person, 1 central this year. And this is, I got you. This year I got you. So Porch Night is a way for not only moms, but caregivers, grandparents to come in and talk about, we now have open conversations, so it's not topic-based. It's what you need at that moment, at that time. Again, meeting families where they're at. Staying connected, please, find us. We're on Facebook, Twitter, LinkedIn, Instagram, probably other things. We're on YouTube too, which is where all of our webinars are housed. So please make sure that you follow us to stay updated. Also, a lot of our emails go to spam, so please add us to your inbox so that you can stay updated. Thank you to our sponsors for these workshops, because without them, we couldn't do these. So these are all of our sponsors for our family workshops, a few who are here today. And again, we just want to thank you for being here. These are our proposed locations for 2024. We have Louisiana, which is confirmed for April, Charlotte, North Carolina in May, and then we are looking at Portland, Maine, and then we've actually changed Omaha, Nebraska to Iowa City, Iowa. So yes. Well, we'll see. I have to look at the weather. So
This is the Midwest.
I know, but which one's better, Maine in October or Maine in November? These are my questions.
That I don't know.
Because it's cold.
80 degrees on one day to 40 degrees.
But Billings is real cold now, but wasn't last month. So anyway, these are.
Switch it around, like Charlotte, North Carolina needs to go to November, and the Midwest or put them in.
I know, you're right, but those are confirmed, so we can't switch them around now.
They're already what?
Confirmed. But you know what? That's good to 2025. So again, thank you guys for being here.
All right, so we made our introductions. My name is Dr. Zarah. By training, I am a pediatric pulmonologist and sleep medicine provider. This particular topic was a request from one of our patients, and Dr. Emerson said, sure, wish granted. So here we go. Okay. So the topic that I was assigned to give is non-invasive ventilation. And I decided to break it down into 3 parts: the what, the why, and the when. I think that's gonna be hopefully easy to understand. Speaker disclosure, no relationship with any commercial firm or products related to this conference. Okay, let me begin by talking a little bit about NIV, or non-invasive ventilation. So just looking at, the words in here, non-invasive ventilation. So this would automatically exclude anything invasive. So anything that is delivered through a tracheostomy tube or delivered through an endotracheal tube. So we're basically talking about the delivery of positive pressure ventilation without a tracheostomy or endotracheal tube. Simplified, it is the combination of a device or a machine, and there are many machines out there, connected with the tubing to an interface and a mask. There are, again, so many varieties of a mask, and I have some pictures that I can share later, and of course, the patient airway. By and large, the usual modality that is used in patients with muscle weakness or Duchenne muscular dystrophy is bi-level PAP. So this is the introduction of 2 pressures. So you have a high pressure and then you have a low pressure. The high pressure matches up on your pressure at the end of the inhalation. And then as you exhale, there is a residual pressure that's called the EPAP that is always keeping your airway open. So let's try to distinguish CPAP versus BiPAP. And the reason why I want to talk about that is I think as a community or maybe some family members of ours will have CPAP. and you're going to say, ooh, I have CPAP, or my family has CPAP, family member has CPAP, which is mostly prescribed for obstructive sleep apnea, okay? CPAP is here. It stands for continuous positive airway pressure, and it is when the machine delivers a single pressure, say 6, and it's always going to deliver 6. It doesn't, when you exhale, it doesn't adjust to your breath, and when you exhale a little bit, it gives you a little bit of, they call it an EPR, so a little bit of an exhalation pressure relief, giving you a little bit of a break when you exhale, and then you will inhale again. So some of our patients, let's say some patients with Duchenne could be diagnosed with obstructive sleep apnea, just like any other children. And it's mostly due to, let's say, excessive weight gain or the presence of adenoids and tonsils. Now, by and large, I really would not advocate for use. Let's say if a patient with Duchenne muscular dystrophy would need some PAP therapy, I would not advocate for CPAP. I would always advocate for bilevel PAP. That's the next picture here. So bilevel PAP, 2 pressure, 2 distinct pressure. You have a pressure, the IPAP, inspiratory positive airway pressure, that you will get as you inhale, and then there's an EPAP, an expiratory positive airway pressure, as you exhale. So this mimics, this probably better, yeah. This mimics your breathing a lot more naturally. So in comparison, you have normal breathing here. This is what you call your tidal volume, the volume of air that you inhale and exhale in each respiratory cycle. In CPAP, you only have 1 pressure, so you really need to try and make an effort, let's say, to breathe over it, because there's only 1 pressure. Whereas if you have BiPAP, see the arrow there, if you have BiPAP, there are 2 levels. There's an IPAP, and then there's an EPAP. So the breath is actually, so it's very hard to manage this mouse. Okay, so when you start off a breath, you would take a deep breath as you initiate a breath, and even if it's a weak breath, the IPAP supports you and help you make a good inspiratory effort, and then it would relax back down to EPAP to help you exhale. So by and large, if there is someone who's diagnosed with an underlying neuromuscular weakness, we always, for the most part, you really have to convince me otherwise, to go to anything but bilevel PAP, okay? So the machine that we use for bilevel PAP, there's so many machines out there. We recently, well, in 2021, got a lot restricted. The main giants, I would say, in the industry were Respironics and ResMed. But I'm sure you've heard that in 2021, there was a massive recall of Respironics units, making us more lean. We had to rely on ResMed, and there's Fisher-Paykel, and there's some minor companies. But by and large, the one right now that is, of course, an established company would be ResMed. So these are two bilevel PAP machines. You can see here that there is an integrated humidifier where you would put your distilled water, sterile water. They look very similar, but really the difference is some devices are, when you place an order, you can put a rate, or you can just put spontaneous, meaning it just would try to mimic the natural breath and would not have a backup rate. The backup rate really is just fail-safe mechanism so that you will have a minimum respiratory rate during sleep. Okay. Sometimes bilevel PAP machines may not be enough, and we need to go 1 step up, or if we want to introduce a different mode of ventilation, these 2 units here, the ResMed Astral and the Respironics Trilogy, which is currently in recall, but they made some revisions. So you may find some Respironics Trilogy Evo in the market. These 2 are really devices that are meant for invasive ventilation, but they can also do and deliver bilevel PAP, and they can even do a sort of an upgrade to the bilevel PAP, which is your volume adjusted pressure support, or your VAPS, AVAPS or IVAPS. How is PAP or NIV delivered? So first of all, I guess when I set a patient up for non-invasive ventilation, either in the sleep lab or in the hospital, I always aim, my first go-to is a nasal interface. Again, there's so many interfaces in the market. If you go online, you can research and you think, oh, I think I'd like this better than the other, go for it. I think you really need to try a lot of the masks to find out which one works for you. So I usually start introducing a nasal mask interface. Some people like this nasal cradle where it just sits on the bottom of your nostril, and some people love a nasal pillow. So I usually give several options. I usually give several options and have the patient and the family decide what works for them. So I know I have patients who like the low profile because they want to watch TV. If they're relaxing and they're settling down to sleep, they put their mask on, they want to watch TV. Okay, so that's important for you. I think I want to add on extra additional types of masks, only so that you would be familiar with them. But these two masks are usually used during acute care or during a hospitalization. This will be your full face mask, something that covers the nose and the mouth, or your total face mask. This is the Fit Life. Some people call it the scuba mask. And it covers the entire face. Okay? Some people love it. You would say, oh, I would be extremely claustrophobic, but there are some patients who love it and would not change it for anything. So that's okay. So again, in acute care, when we have a patient with Duchenne muscular dystrophy coming in for needing some oxygen, needing a little bit of support, have a lung infection at that time, or someone who's dealing with post-op. So usually we may use the total or full face mask and then hopefully revert back to the nasal whenever there's stability. Okay, so NIV, non-invasive ventilation, why? Why do we need to talk about it, and why does it work? It does work. So I want to look at the left image here, and it looks at your inhalation and your exhalation process. So during inhalation, the most important muscle is really your diaphragm. And as it contracts, you take a deep breath, it contracts down, it increases the volume of your chest wall. So the primary muscles, I would say, for inhalation would be your diaphragm and then your rib muscles. So it would expand, your external intercostals. And then, so the act of inhalation is very active. You have to, if you want to do just a regular breath or if you want to do a deep breath, but it's an active process. Exhalation is mostly passive. So exhalation here, where everything reverts back to its usual position. So the diaphragm then again would come up a little bit, and then you would relax your rib cage. Now, I think it's also important to talk about the muscles that we use for exhalation, not just because it's a passive activity, but these are the same muscles that we use for coughing. So for me, inhalation is important. Coughing is extremely important as well. So these would refer to your intercostal muscles. These would refer to your your abdominal muscles. And these together will help you make an effective cough. Another important group of muscles, so our respiratory muscles would be the ones that we use for inhalation, the ones we use for exhalation or a cough, and the third one would be our upper airway muscles. So it's really a very complicated contraction and relaxation of different muscles. So this would mean, so like on here, you have your oral, when we take a deep breath, we can breathe through our nose and through our mouth, and it goes through the back our tongue is also very important. But then we have to look at our pharynx, our oropharynx, our epiglottis, our larynx, and then our upper airway. So non-invasive ventilation works. It's because when we have respiratory muscle weakness, so if it involves muscles responsible for inhalation, like your diaphragm, your external intercostals, your sternocleidomastoid or scalene muscles, I'm probably killing that, which are the muscles on your neck, and then exhalation, your abdominal and internal intercostals. It is also important to talk about your upper airway or your bulbar muscles. They're called bulbar muscles because the innervation comes from the bulbar portion of our brainstem. So these are the muscles, pharyngeal and laryngeal muscles, they use for speaking, chewing, swallowing. So you probably know me that when I see you in clinic, I always ask, how are you eating? How are you swallowing? How do you feel confident that you're able to swallow good? Okay, all right. So non-invasive ventilation is used in respiratory muscle weakness because, remember, if the muscles that we use for inhalation causes us to have decreased tidal volume, meaning that the amount of air that moves in and out of our lungs is decreased, so it addresses that. In respiratory muscle weakness, this leads to hypoventilation. So think about it if we always call it the respiratory pump. So think about it if instead of a good breath, your breaths are shallow, it is very difficult for you to exhale CO2 or carbon dioxide. And this is really a very important gas, and actually a gas that we follow very closely when we deal with a patient with neuromuscular weakness. So remember, when we breathe in, we take in oxygen. When we breathe out, we exhale carbon dioxide. So we know that if your tidal volume or the volume of air that you move in and out, the more it decreases as a function of decreased muscle weakness, your CO2 rises. So for us, that is a marker. So we always try to pay attention about your CO2. Now, we all know that in Duchenne muscular dystrophy, we always work on trying to improve airway clearance because our cough is weak. It leads to retention of secretions, it can cause aspiration, and it can cause pneumonia, which further affects our lungs and further affects gas exchange. Okay. Also, our upper airway, if our upper airway muscles are weak, it can cause drooling, trouble swallowing, difficulty speaking. So this is just a quick diagram of when we have respiratory muscle weakness that involves the bulbar or the swallowing muscles. We have upper airway dysfunction. When we have expiratory muscle weakness, we have the inability to produce a good cough. And then if we have inspiratory muscle weakness, we have ventilatory dysfunction. Eventually, it leads to respiratory insufficiency and what we call here as sleep disordered breathing. So non-invasive ventilation in Duchenne muscular dystrophy is primarily used in two main types of diagnoses. One is obstructive sleep apnea, and the second one is respiratory insufficiency. So obstructive sleep apnea, which is defined as your partial or complete collapse of the upper airway during sleep. The symptoms that we would notice with snoring, gasping, restless sleep, arousals. Sometimes it causes you to have a lot of arousals during the night, so that in the morning you're just so exhausted because you did not have a good night's rest. This pathophysiology is very similar to obstructive sleep apnea in children and obstructive sleep apnea in adults. So early on, a patient with Duchenne muscular dystrophy can have enlarged adenoids and tonsils, or maybe is a little overweight, of course, because we are supporting them with oral steroids. These two images here it looks at the typical breathing during sleep. So during sleep, the upper image here is normal, so you have a good flow of air from your nose and your mouth, and it's able to go through your past the epiglottis and down the vocal folds. And then, or you have something that would cause an obstruction, either decreased patency in this area caused by a large tongue, weakness of your pharyngeal muscles that would cause collapse during sleep. One other thing that I think I want to just talk about is children with Duchenne muscular dystrophy. Apart from the increased risk from age 2 to 8 of having adenotonsillar hypertrophy, we have to acknowledge that there is a progressive muscle weakness. So this progressive muscle weakness, I think the earliest sign that we could actually see it happening is during sleep. So in sleep, we are naturally shallow breathers, right? We all know that children with muscle weakness have muscle weakness when they're awake, but this is even more profound when they go to sleep and they hit REM sleep, or rapid eye movement sleep, when there is muscle atonia. So that muscle atonia further contributes to worse gas exchange during sleep. So respiratory insufficiency, the other indication for non-invasive ventilation in Duchenne. So the other one was OSA, this one is respiratory insufficiency. This is when you have hypoventilation or high level of carbon dioxide in your blood. Sometimes you can have, or usually you will have, if you have hypoventilation, you would have hypoxemia, meaning low oxygen level in your blood. Initially, the first sign is really observed during sleep, and then you would see it carry on through the day or when awake. The initial symptoms would be daytime sleepiness, sometimes you've got a headache. The elevated CO2 causes the vasodilation and causes headache. And then sometimes during the day, you would find it difficult to learn and concentrate. Later on, as disease progresses, you will have difficulty in breathing, fast and shallow breathing, orthopnea, or you would be reliant on sleeping in a relatively upright position to assist your diaphragm. You would observe that as well. And then you would use accessory muscles for breathing. So then you're trying to augment breathing by recruiting other muscles. All right. So having all of this pathophysiology and background on positive airway pressure, how do we then piece together and discuss what to do next? Okay? We rely a lot on help, and this is help from guidelines. So for pediatric pulmonologists or pulmonologists in general, we rely a lot on ATS guidelines. This is the American Thoracic Society documents. One of the really good articles, good read on respiratory care of the patient with Duchenne muscular dystrophy. Actually, when I trained these, some of the authors on this paper were like my mentors. So this is a very, very good paper for you to kind of refer and kind of scale back and see where we are, or where is a center at in terms of standard of care. I just realized it's 2004, so that kind of dates me a little bit. Okay. But, huh?
You think there's a few updates since then?
Yes, so this is the parent, I'm sorry, I lost my, okay, this is the parent article. So this is where everyone kind of patterns care as standard, but there have been, since then, so many other ways to diagnose. Since 2004, they standardized polysomnograms already, so there's just a lot more added on to this. But this is kind of like the parent framework, and then we have advances since then. But I think it's still a good read and a good enough article for caregivers as well to appreciate. Okay. I do want to stress that in care of a patient with Duchenne, we all know that. We have to have a multidisciplinary team approach. Not a single person would be able to do everything, because what's going to happen is you're going to focus on your subspecialty and ignore the rest. And we all know it does not work that way. So for us, we rely on our therapy, we rely on PM&R, we rely on neurology, we rely on nutrition to keep us all good, we rely on our cardiologists. So it's always a team approach. And I think what is good, if you work as a team, you share information. You're going to say, oh, I'm really worried about this pulmonary function test. Why do you think? And so on and so forth. Because I think some of your decisions are very much influenced by the input of your team members. Okay. I also want to stress out the importance of regular follow-up. So we cannot assess you if you don't show up to your visit. It's extremely hard. And we would try to do everything. We try to do some telehealth just to kind of get a sense of where you are, but it's very important to show up. The other thing that I would also like to stress is anticipatory guidance. So we know and track, if we test you, and I'm just going to refer to my specialty, with pulmonary function tests, or let's say with a polysomnogram or a sleep study, we know exactly what's happening right there. But we will not know how to do a good job if we don't have the tools or the assessments. Okay. I also want to stress out preventative strategies. Immunization. Whatever you can give to prevent exposure, prevent progression of disease, even just a flu shot. We always recommend that for our patients. Okay. All right. So when do we start? So non-invasive ventilation, what we do is we track. So it would be really good. I'm sure you're all very active in the Duchenne community. You know that when you follow up with us in a muscular dystrophy clinic, by the time you hit 5, you're going to do pulmonary function test. And I'm sure some of the parents will say, what are they doing with that? They're not really doing anything much, just following. I think it's tracking. We need to establish a baseline where you are so that and I'm just going to say, when someone is getting weaker, AKA wheelchair bound, we know exactly what to expect, and we know exactly where you're coming from. So it's really a trajectory that we're trying to follow. So when we look at your pulmonary function test, we look at your forced vital capacity, which is the amount of or volume of air that you breathe in with a full inhalation. And we measure your FEV1, which is your forced expiratory volume in 1 second, the amount of air that you can blow out in 1 second. And these numbers we tag, because these are the ones that we know and follow. Oh, you're less than a liter, we need to give a closer eye. So it gives us, these are really objective data for us to say, we got to start talking about this. Oh, we got to start talking about this. We also measure a MIP and a MEP. I know some of my Duchenne kiddos just absolutely hate this. It is not the most comfortable maneuver to do. So the MIP the MEP is a maximum inspiratory and expiratory pressure. This is when we have them blow out naturally, and then we close a valve and we tell them to create or suck in against resistance. So it's really very uncomfortable. No one would volunteer to do it, and then all of it, the respiratory therapist or our PFT folks would just say, they just don't want to test anymore. I said, okay, fine. So it's not to torture you with every single visit, but it's for me to know when can I intervene. So if I know that your peak cough flow or your MEP is decreasing, we got to talk about a cough assist. Right? We got to talk about a cough assist. We got to talk about treatments. What can we do proactively so that you won't land in the hospital? Because if not, what we're going to do is we're going to wait until someone gets admitted, develops a pneumonia, and then we learn. And that's just really not the mindset anymore. The mindset is to identify when we're weak, start the process of helping, because sometimes you introduce the idea of a cough assist and they're so resistant to it, but if you don't practice, what are you going to do when you're sick? Then you're even going to hate it more. So for me, it's the process of introducing a particular device and then from there getting the hang of it and getting to know how to use it. Okay. We also do measure carbon dioxide in clinic, and that's a recommendation to at least measure every year, if not every visit. We don't need to do a blood gas. We can just do capnography or end-tidal CO2 measurements in clinic, easy enough and non-invasive. We follow with an annual chest x-ray. Really what I do, sometimes I tag on to Dr. Emerson's scoliosis checks. So I just look at the lung fields, okay, I'm good. But I mean, she's the one who would follow up scoliosis and then from there determine if a referral would be needed to orthopedic surgery, okay? All right, so in non-invasive ventilation, when we talk about non-invasive ventilation, we always talk about a good sleep evaluation. So we talk about what happens during sleep. I think I mentioned this to you already. Decreased central ventilatory drive, decreased upper airway muscle tone, and then we're even compromised when we hit atonia during REM. We always review sleep quality and symptoms, because sometimes things like, oh, I always wake up in the middle of the night and I feel like I'm breathless, or I wake up in the middle of the night and then my head hurts. So subtle things like that come on, and I think we need to follow those symptoms closely. If there is a concern for generally what we call sleep disordered breathing, we order a polysomnogram. I know when I start discussing about a polysomnogram, they always like roll their eyes because they say, we're never gonna sleep, we're never gonna sleep. But I said, we really need the data. Again, it's the CO2 during sleep that counts, that really is our marker, okay?
The awake studies.
I'm sorry?
That's the awake study.
Yes. But you know, in time,
When you get, I'm just going to say this, when you have kids on the spectrum, that is an awake study.
yes. So we have several things that would help. Well, for some patients who have been in the lab, they know what to expect. But for some who have not, we do offer a desensitization protocol, especially for kids with ASD. We do offer, well, we try. We try to offer some.
7 years of doing them, it was an awake study.
So we do try to offer some desensitization, and that would mean having like some nasal sensors or some stickers, or even touring the sleep lab for that. I mean, try to do a study. Again, it's not to torture our patients, but we really need the data. What am I looking at? I'm looking at obstructive events and CO2 during sleep. I will never capture CO2 during sleep if you're not in the lab. It's just not possible. Okay, all right, so this is how it looks like. There's really, there are EEG leads for us to detect which stage of sleep. You have an eye EMG marker, you have chin EMGs, you have, unfortunately, 3 sensors that would measure your pressure transducer airflow, you would have a thermistor flow, and then you will have end-tidal flow. There is a chest and abdominal belt to monitor your breathing. There is a pulse ox somewhere in here that's attached to a finger, and then there are leg EMGs, okay? Up close, it looks like that. So after they're hooked up, they're gonna say, okay, time to go to bed, okay? So for some who've been there, they know how to fall asleep. In a pediatric lab, and I'm just gonna say, because I have not worked in an adult lab. In a pediatric lab, we always have a caregiver in the room. So there's always a parent who's in a separate bed. I think it helps the patient relax that there's backup. There's someone that they can call if they need something, okay? It's really not that bad. It's really not that bad. Okay, all right. So when do we initiate NIV, or non-invasive ventilation? This is when we see on our sleep study multiple central and obstructive events, when we see high CO2. So when we use NIV, it actually helps you breathe during sleep. So it actually improves ventilation, or it lowers carbon dioxide. It improves oxygenation. It improves your sleep quality. And improving your sleep quality and improving ventilation during sleep actually carries on to improving daytime gas exchange. We have a lot of data that supports use of NIV during sleep, actually promotes a slower decline in pulmonary function. Okay. Again, I think I mentioned this before, nasal intermittent positive pressure ventilation is the way to go. There are, of course, several complications, mostly associated with the mask interface. So sometimes you can have eye irritation from a leak. You can have skin ulceration. Sometimes you get a little bloating, excessive gas in the stomach. And sometimes when you're really so full, sometimes some of our patients have episodes of vomiting. So I think this is the point that I really want to stress out. We always try our best to use a nasal mask interface, either a pillow or low profile or what have you, when we deal with non-invasive ventilation in children with Duchenne. Only because if you have an episode of vomiting and they are unable to remove that mask, then you have the risk for aspiration. So focus is always first line nasal. Okay. I was always taught by my mentors that if you figure out your pressures well, or adjust your mode of ventilation well, you will not need a full face mask. And so far, it's been kind of working. So really, I always want to stick with the nasal. Okay. When do we then think about, so we then have a patient who has non-invasive ventilation at night. When do we then say, it's time to talk about non-invasive ventilation during the day? So this is when you have daytime hypoventilation. So typically we consider if you have end-tidal CO2s greater than 50 when awake during the day, or you have oxygen saturation less than 92. Now we have to factor in, there are many causes of low oxygen levels, but just the fact that you have elevated CO2 will actually affect your oxygen saturation. So at some point, you're gonna discuss with the family and you're gonna talk about options, okay? When you have determined that you really need 24-hour support, you're gonna talk about options. And as a practice, we give out all the options. I don't think the specific preference of the provider should affect the decision of the patient. Or the family, actually, as a group. So you give your options. You talk about invasive ventilation. You talk about the pros and cons of having a tracheostomy tube and having a ventilator. That's number one. Or two, you talk about non-invasive ventilation, meaning having some NIV at night, which is what they have, and then think about how you're going to support ventilation during the day. I know questions have come up, why can't I just wear my setup at night, extend it during the day, okay? I know questions like that come up all the time. We really try to stay away from using the same setup at night to using this to the day. Our skin is our access. So when we lose a good access or when we develop ulcerations, then that means we cannot use our mask anymore, or we have to change up the mask. Then we deal with, ulcerations, we deal with infection and whatnot. So it's really not ideal to use the nighttime setup for the daytime setup. When we talk about these options, usually what comes up is, I want to stay non-invasive as long as I can. Sure, so we'll talk about that. So here is when you utilize your nighttime bilevel PAP, whatever your setting is, and then you talk about what's called SIP ventilation or mouthpiece ventilation. Okay, sorry, before I proceed, let me just talk about invasive, non-invasive, and 3, no additional treatment or therapy. And if that's the direction that the family would like to go, I think we should respect that. So, okay. When you talk about SIP ventilation, or this is your mouthpiece intermittent positive ventilation, the setup is you have a device in the back, so it's almost always a ventilator type of device. You have like a little arm that supports and then a little mouthpiece there. So people have referred to this as SIP ventilation or KISS ventilation. So I guess the mouthpiece is the one that delivers usually it's volume driven. So the patient would get the lip in contact with the mouthpiece and it would trigger a volume breath. Okay, I think that's all I have. Am I over time? Sorry.
We started, but you're good.
Okay.
Does anybody have any questions?
No questions?
Oh, we do have a question.
Okay, go ahead.
For the SIP ventilator, what kind of sort of latch or closure around the straw piece do the patients have to have? Is it a very tight closure or is it any type of contact? How does that work?
Usually it's contact. So we all know that with bulbar muscle weakness, it's very hard to completely occlude that. Usually it's just by contact. That's why they have said KISS. So it's really just contact and it will produce the volume. Now, this particular type of device, I mean, all of our BiPAP setup units have an exhalation port, right? Because we need to exhale CO2. But with this, just the contact delivers the breath and the exhalation would come naturally. Yes. You're welcome. Yes.
So, thank you. This is very informative. You mentioned about that you do a lot of tests, especially CO2,
Yeah.
to find indication when you're going to give the non-invasive
Yes.
ventilation.
Yes.
So, as we know that the patient they have weak muscles, diaphragm and the chest muscle.
Yes.
So, is there any negative impact to do as early, even before you have the signs of CO2 change? Say if you do, okay, this is the first time I saw patients, okay, I'll tell them probably you need to start since it's non-invasive. So would start sooner be something worth to consider, or you have to wait until the CO2 reach certain?
So by standard of care, we don't wait for extreme hypoventilation. I mean, we're talking about if it fits our rule book for when we interpret polysomnograms would be the AESM rule book. So they have a definition of hypoventilation, which is 25% of total sleep time. So when we reach that or when we're approaching that, mind you, these are very, I would say, early signs or early objective data. So once we see that, then we start talking about non-invasive ventilation. I honestly don't know the benefit if you're starting NIV on someone who is normocapnic. Because what are you going to treat? Because what will happen is you may drive the CO2 even lower, and then you don't know what that will, I feel like when we do a certain strategy, and it's a big commitment for the family, I always try to justify it. This is the data that I have, so I'm going to follow guidelines and I'm going to start. This is very sensitive, I'm going to say. So it's almost, I think I would similarly do an analogy of taking your tonsils and adenoids out when your sleep study is normal, right? So we won't approach a surgical intervention if it's not indicated.
So in your what age patients start have this non-invasive?
So for me, the biggest sign is usually when they're wheelchair bound. So in fact, when they're wheelchair bound, we try to do a study every year.
To the right on the left-hand side. But I am going to bring up Dr. Emerson, and she will be talking about navigating IEP and school services in Missouri and beyond.
I'm gonna try to make up some time.
You're good. You're good.
Okay.
We'll make it up somewhere if you gotta talk.
Well, that's all right. So basically, as I said earlier, I'm a peds PM&R doc. And in the last 2 PEDS MDA clinics we've had here, we've had a lot of Duchenne patients, because right now we have multiple of them clustered and of all different ages. So we asked them kind of what they would want to hear about at this meeting, and then we tried to cater to that. And some of that really surprised me, honestly, but I was really glad to have the input. And obviously, there's great variations with Duchenne and what a 5-year-old needs and what a 21-year-old needs or wants. And I would say to you guys as I'm talking, who are out of school or at the end of school, know, and I would empower you that you can be an advocate for others, especially, Thomas, since you speak so eloquently.
Yeah, definitely, and having had an IEP, I can also back up some points if you need.
Yep. And I think that it's much more important to hear from him than me. But I saw this just last week on Facebook and saw it as a divine intervention for this talk. And it's a quote, and it says, "I think the hardest part of having a child with a delay of any kind is the fight. The fight for services, the fight for people to understand who your child is and what they need. The fight for knowledge, because knowledge is power, and the quiet fight you have within yourself, wondering if you've left no stone unturned." And I thought when I read that, boy, that describes a lot of my families and patients, not just in Duchenne. And I think as we talk about school-related issues, especially because we know that education is so paramount as kids are developing, and parents always feel like they have to fight. Okay. So education in general in the United States is somewhat dictated by federal law. So there's basically 3 federal laws that have information about how education is done. And one of the things that I want you to notice, we were talking about dates earlier. The latest update to any of these 3 laws is 2004. So that is a long way from today, right? So I think there's a lot of work to be done in this arena. And especially with all of the advances in research and from pharmaceuticals, that kids and adults are living longer and doing better, we need to do better in this arena as well. But basically, we have the American with Disabilities Act, that's from 1990. We have the Individual with Disabilities Education Act, that's from 75 and revised in 2004. And then we have Section 504 of the Rehabilitation Act, which those of you who have been through school systems probably have heard the word 504. In the public school sector, all kids with a disability are guaranteed a free public education. That is not necessarily true within the private sector. The American with Disabilities Act basically says you can't discriminate against someone with a disability, but it doesn't guarantee you a free education. I'm going to talk about in a second what the difference is between an IEP and a 504, which is the programs that most kids through high school utilize to have special services. Okay, so Duchenne, unlike some of the other diseases that I take care of with kids with special health care needs, not all patients need what is called an IEP or individualized education plan. So each school system has to have a reason that they can tell the state or the feds why kid X needs something different than all the other kids in the class and why they're doing something special for them. And the most robust plan that a school system can give you is an IEP or an individualized education plan. But understand that an IEP typically means that you need the curriculum changed for your education. So for instance, if you're a patient with Duchenne that does not have learning issues, that does not have cognitive problems, that can do the regular core curriculum with appropriate physical accommodations, then you don't need an IEP in the law of the land. Now, some schools may still give you that, and if they do, that's great. The 504 plan, which again comes under the Rehabilitation Act, expands the definition of disability and provides more accommodation, but typically that's going to be for someone who does not need a curriculum change to their education plan. And on the far side of this slide in blue, this is showing you the actual qualifications, some of them by diagnosis that you'll see. Like, for instance, autism has its own traumatic brain injury. But you'll notice really fast, neuromuscular disease, nor Duchenne, like fits in its own category. So one of the things that makes Duchenne boys eligible for special education is the category of other health impairment, right? School systems then use all of this, and they vary greatly. I would say even in Columbia, we have a huge catchment area because we are largely everything that's not St. Louis and Kansas City. And so we have suburban schools, some city schools, and a lot of rural schools. And the family that asked me to talk about this is having lots and lots of difficulty currently with their school system. And I will tell you, this is a younger boy, less than 10. And I think not wheelchair bound, so not as obviously having a impairment. It is somebody that's getting infusions, sometimes at school, and is in a rural school. And remember, we don't want it to be all about money, but some rural schools, obviously, you know, their ability to pay for the special needs or to provide services if they don't have therapists that are in their school or whatever a child needs may be problematic. So the biggest thing I would say, and that's what I told this family, you have to advocate for yourself and what you and your family needs. And there are multiple online references through multiple advocacy committees. In Missouri, and I have this on the next slide, there's an organization called Impact, which will help families with special education needs that would have to sit at an IEP table by themselves with a big group, know what to do and kind of how to navigate it. And, you know, the first thing I would say is try to advocate and be appropriate behavior-wise with your school, which is sometimes hard. Be level-headed. The family that asked us to talk about this, the dad's pretty reactive and laughed and said, I'm not allowed at any IEP meetings per mom. And, you know, for that family, I would say it's great that you realize that because you, one, need to know what you want from the school, okay? And then you want them to be on your side, not to be against you. So you've really got to get organized. You've got to know what you want. And you've got to know the law and what you should have. And you may need support of your medical team, support of your community. One of the things that I've seen through the years, especially in kids with special needs that are in small schools, is that they come to this place where they really need to fight the school hard legally if they want what they want and need. But then you keep in mind that's their community, their friends, the folks they go to church with, the folks they do other things with, and they've got to live in that community. So that can sometimes be a very hard issue. In Missouri, and I'm sure in other states, you've just got to know what your process is. There is something called a child complaint process that you can enact on the behalf of a child if you and the school can't come to a happy medium of what's needed. Interestingly, legally, there's a site online where you fill out that complaint, and then that goes to the state, and you have to fill out something and tell the school that you're filing it at the same time. And remember, again, that if you choose to put your child in a private school, then some of these things don't apply. But in a public situation, you can file this complaint and they have 90 days to investigate it and enact. And there's also mediation processes that you can go through with schools. So this is the website for Impact, and I think since COVID, at least what I've heard in general, and this is Missouri specific, but they have had less of a presence, like physically with the patients in the school system as they did previously, but they have a very strong website that gives lots of information, and so does the PPMD. And then there's Missouri Protection and Advocacy in Jeff City, which can help you also with these issues. Okay, and then I want to just talk in general and hear some of your experiences, but I saw this also, I and the I in IEP, and I think as a medical team, I think about this a lot. Many times we think we know what's best for a given patient, and in the school setting too, I think being able to listen to the patient and really think about what they need and want instead of what we anticipate they need and want is very appropriate. So Duchenne, actually, in my experience, I have had less problems with school-related issues, IEPs and 504s, than other muscular dystrophies or other developmental problems. And some of that, I think, may be that especially as you get older with Duchenne and you're wheelchair bound, it's more obvious that you have a disability. I have had a school here lately that is not accessible. And you think, well, how can that be in this day and age? But it can if it's a rural school. So obviously that's a big problem. I think COVID allowed us to look at options for Zoom and online school, which for some people was amazing and life-saving. But in some ways, it empowered schools that may not want to meet the accessibility criteria, a way to just say, you need to be online because we can't get you out of the wheelchair, we can't do your toileting, et cetera, which is an excuse, because I think that although I have patients that really do want to do homeschool, I have many others that need social interaction, want to be with their peers, and certainly shouldn't be told they have to do that. The other thing that has surprised me through the years is how many notes or letters that I, or now Sandy, have to write regarding PE in patients with neuromuscular disease, or dealing with punishments that involved either walking or running distances or writing. Actually, I have a really funny story, and this was not a Duchenne patient, but is a MDA patient that is similar. And when I say that this kid was a pistol, that is an understatement. So I'm sure that he was giving the school lots of grief. But he had a lot of weakness in his hands, too. And they had a whole school policy that when you misbehaved, you had to write sentences. And the sentence was seriously supercalifragilisticexpialidocious, my behavior is quite atrocious, blah, blah, blah. And he had to write hundreds of times. And I can say probably daily because, and again, not that bad behavior doesn't warrant correction, but what I write in these letters is you cannot take a muscular dystrophy patient and punish their bad behavior by using their weakness. You've got to find a different way. But the funny ending of this story is that this kid, who was quite inventive, figured out a way to run these sentences off on his printer so it looked like he wrote them. And they did not figure this out for a year. So you can imagine when they did figure it out, they were quite mad. But I was like, boy, we gotta get this talent turned around because that's good. But I can tell you one of my OTs that is no longer here anymore was about the maddest I've ever seen them of, just this idea. And especially in younger Duchennes, had this just recently, they make them run a mile or run laps or those kind of things. And usually, I don't think the school has ill intent. That's not always the case, but typically, they just need education. And so I think that, groups like this and the Jett Foundation are important. And as I said earlier, I think some of you, like Thomas, advocate for others. Because you're really good at that and have really impressed me. And a lot of the other boys don't have that ability. So, more power to you.
Which is the funny part, I'm like literally, I hate presenting. And yet, I'm like, apparently God said advocacy is my thing. Which is hilarious to give to a shy kid. But okay, I'll take it, I guess. But ironically, maybe the shyness makes it more relatable. But, I'm already out of school, but I've heard horror stories from my mom, regarding, I just left, the school, but it's gotten worse since I left. And, it's just frustrating to learn that it's not been updated since 2004. That's kind of wild to me. So I think, maybe some families just gotta consider going to Congress maybe. Because that needs some immediate, like, I know I'm out of school, but learning that just really burnt me the wrong way. I learn new things every time and I think I can. But, that's kind of my experience is I left and it seems to have gotten worse over the last few years. And no one's really getting the help with the disability that they used to. It's like you said, Zoom and stuff, they have excuses. And, but, there needs to be some fixing.
It's like our son, he's one of the third of the boys that has a learning disability, and he's exceptionally dyslexic. And we had a wonderful group of folks in Jeff City with his IEPs. He went to broken schools, and they were amazingly accommodating. It really surprised us. But one thing we found is we could not find in the state any programs for dyslexic children, which I find unbelievable. I mean, are you aware of any that might be online or that
Not specific to muscular dystrophy.
no, just in general?
And we, until last year, we had a neuropsychologist as part of our PEDS MDA clinic who did testing and who did all that stuff. And now we're looking to hire someone because she moved. But yeah, no. And a lot of the boys do have learning issues. And so obviously trying to meet those, I can tell you on the same note, just, I've found myself in the last 5 years doing a lot more genetic testing than I ever thought I would do. And I also started testing Duchenne boys for other things. And when you start looking, you start finding.
What we found with Mark, the first day of kindergarten, my wife went and actually spoke to all the teachers, principal, and the kids in the class, and explained what he had and all that. And I think throughout his career, he's a senior in high school. And they were all, like I said, they were extremely accommodating. Like, I mean, he does not take the normal classes. I mean, but he enjoys school. He's integrated with his classmates and such. But when you talk about, like the boy being forced to write, or like a kid being forced to walk, we found early on in grammar school that every Friday they would have to know 10 vocabulary words. And they'd have to be able to spell them out, and then they'd have to read. Mark couldn't do either of those things. So we had to go to them and say, is it okay if he just doesn't have to do that? Maybe know 1 or 2 words, and please never ask him to read in class, because that just reinforces something that they're ashamed of and they feel that way. And they were very, very nice to go along right away. We didn't have to
got issues like this, you have to also go in on the page of, you need to educate them as well. And PPMD has an amazing website for school modification recommendations, whether it's in the learning stuff or in the physical PE stuff. They have an amazing website, and it's a lot of pages, I'm not gonna lie, but it might be worth printing it out, taking it up to Office Max, whatever, or sending them the link. It educates and it explains why and what some suggestion options are. And I guess that probably came up, I didn't get to watch your video yet about your IEPs this past week.
Oh yeah, we did that with Jill Castle. We did IEP inside, of course, but the physical education webinar also went over the specifics related to physical therapy, and she did go into what the difference between an IEP and a 504 and when you would ask for one and why you would ask for one is. So that's a great resource. But like she said, PPMD has so many good IEP resources on their website, and I have a lot of suggestions on how to also talk in those meetings and who needs to be in those meetings, more education just on IEPs. I haven't been through all of them, but I also think they have like how to educate the team. And I know that so Jessica Campbell on our team is also a great resource. She actually just sat in on an IEP meeting, so she would be, if she's available and able, willing to sit on those meetings to help as well.
I can tell you from experience, we almost went to the state. But we also realized where Stephen was at that time. By the time we got to a court case, there was a good chance he would have been dead. His disease had just progressed. So we pulled him out in homeschool, made up his sophomore year, and he was 3 classes away shy of graduating high school at home before he passed. So there are other options to do, because we found a homeschooling program that we had support come in and help out with. It had no live cameras, had no audio that was required to speak with or anything. It was an amazing, and you could work at your own pace. So if we were inpatient for 3 weeks, because Stephen liked to go and stay and flirt, because that was what his goal was in life, is to flirt with all these girls. Because 1 week sales ended up into 3. You wouldn't get penalized for missing class. It was all at his own rate. So there are other options out there, but like I said, PPMD does a great job of educating the school system of, what to give them, to educate just about the disease itself, and then goes into recommendations of how to adapt as needed
And
and
they,
why.
I don't know if they do or not. I'm sure you could reach out and ask, but I don't know if they have anybody that will sit on the
I
IEP.
don't know about that.
I don't,
I'm not sure.
yeah, I don't think they
I
do.
don't think they do. Okay.
In contact Jill, and she'll.
But like I said,
She's usually, yeah,
but
really
not
great.
to actually.
So I know Jessica will, if she, like I said, if she's available. So definitely, yeah.
And I guess I would say patients that are having true learning issues with Duchenne deserve neuropsych testing. And that neuropsych testing, I still believe, probably should be done in the medical arena, even though some of it's done in the school arena, because the medical arena has no bias about the outcomes. And then you have a nice 8 to 10 page report that the school can't argue with.
And I've worked in special ed for 20-some years, and sadly, one of the things, depending on the school district you're told is, you're not allowed to tell a parent you should have your child tested. Because as soon as you do that, you just now said the school will pay.
Yeah.
So you kind of have to backdoor it, or you have to sit on your hands. But if you say you really should go to Iowa City, or you really should have some outside testing, now it becomes the school told me to, or the school's responsible for the expenses relief.
We had it done, but outside of the school, and then they wouldn't accept it.
Interesting.
Do you know James Boyce?
Why do I know that name?
Well, James, he was on the board too at DMD, and
Okay.
he has a son with DMD, and he's a pediatric psychologist at Baylor.
Maybe that,
And
I
he does
actually
a lot
have
of
reached
work
out to
in-
him, yeah.
He does a lot of work in like the learning disabilities
Yeah.
and the other spectrum. And we actually went down and had James test Mark to
All right, thank you.
Thank you. Now we're gonna go ahead and switch over. Thomas Canter is gonna speak, and Dr. Vovanti Jones is going to facilitate. So I will have them both come up here. We don't have a presentation for this one. And then we can give you both microphones.
Can you hold it?
I can hold it.
No, I'll need some help.
He'll need to.
Julie can hold it. You can? You got it? Okay. On? Yeah, yeah.
Is this thing working? Is it?
Yeah.
Okay, cool.
Want to test it?
No, I just did.
All right. Well, good afternoon, everybody. Just so everybody gets to know me, I am Vovanti Jones. I'm actually one of the neuromuscular physicians in the adult clinic. So for anybody who transitions over to adult care, they will be seeing me with the rest of our neuromuscular team here at the university. So
What's your favorite animal?
my favorite animal is a koala.
Ooh, we haven't heard that one today. I love that.
Yeah, but koalas are kind of the saddest animal there is, unfortunately.
They are.
Well, okay, so legitimately, scientifically speaking, they're the dumbest animal species we have on the planet.
That's pretty true.
Yeah, but when it rains, they just get mad. They don't even know what to do. That's also why wildfires are a threat. They're like, oh, I'm on fire.
Yep.
Okay.
They are. But I mean,
Yeah.
it's because they're cute
They
but
are
sad. And so they need somebody to look out for them.
They need a little love.
Yeah. Yes.
They're still cute, though.
They are.
Yes, they are. Well, this afternoon, we wanted to take an opportunity to just talk to somebody who's living with Duchenne and really get your opinion on maybe some of the thoughts of new technologies that are coming from it, and just telling me a little bit about you and your life about things. So with that being said, tell me a little bit about how you ended up here today.
Dr. Emerson did it.
Yeah. She's pretty good.
Very persuasive.
It's like
Yeah, it's her fault. I mean, it's a good thing, but I mean, she didn't have to do much convincing, to be honest.
Okay.
It's like, would you be interested? I'm like, yeah. She's like, are you sure? I'm like, yes, I just said that. So, yeah. And my mom was like, yeah, we can make that work.
Yep.
Just, she's like the driver.
Sure. Well, how about this? I always like to hear a little bit about your kind of upbringing and how you got to this point where you're here with us today and we're kind of talking about Duchenne care.
Yeah. Well, first of all, whenever you find out someone has Duchenne, your family will never be normal again. Just get used to that. We're not a normal family by any sense. But, learning that being normal isn't actually being normal is pretty good. Because, well, it was actually my cousin, my younger brother, we discovered I had it because he was outdoing me at a younger age, which, isn't normal.
So how old were you when you were diagnosed?
5, almost 6, I would say. That's what I remember.
And when you think about your life pre-diagnosis, if you can remember back that far.
Boy.
Yeah, I was like, that's a long time
I
ago.
remember.
And compared to, say, now, what do you think some of the things that you would tell your younger self?
Definitely not to fight some of it. I would say avoid things as long as you can, but once it becomes necessary, maybe
fight it a little less at that point.
So what kind of things do you think you fought?
Well, one of them was my leg braces, but I personally think, that should be a decision based on the patient because, once you, well, okay, when you're walking, they're important, but once you get put in the wheelchair, they honestly become pretty useless. And I wore stuff for that reason for a long time, and that was not worth it because, it just delays your feet turning in, which honestly, it looks painful, but I think it's kind of cool because you can freak people out. Like, ooh, look at my ankles. They're like, does that hurt? I'm like, no, it just looks funky.
Yeah, true. So in your case, did you only have the AFOs just on your ankles, or did you ever do any of the longer braces over your knees
They
or your
went
hip?
up to right at my knees, I think. But we had these things you get to put on top. For whatever reason, you had to put this thing on top of your ankle because it would rub it the wrong way. I had a bad habit of hiding those. Eventually, my mom figured out my hiding spots and went, "You hit them again, right?" And I'm like, "No." We called them Pringles because that's exactly what they look like. But yeah, I'm like, I'm gonna hide these because I don't want to wear them. I hated wearing them.
Were they hot or
Just
why'd you hit 'em?
uncomfortable and heavy. So me being young, I went to my mom's room, and typical mom, she would always go, "Oh, what? Freak out, And be like, "Oh, you want those off, don't you?" It's like, yeah. And that was fun.
So how old were you when you started to use your wheelchair more full time?
Age 11. Just it's hard to explain. You literally, I started getting weaker and trying to, grasp at independence while I could. You literally just wake up one day and your brain immediately knows that your life just changed that day. I just knew from a certain day. It's like, oh, this is it, huh? It's weird to explain, but that's just what it is. It's weird though because you're not upset about it, you're not happy about it either. It just is. It's just the reality, I guess.
And so when you made that transition to using your wheelchair full time, how did your life look outside of that? What changes in activities were you able to do and your interaction with your peers in school?
Well, at that point, I basically quit swimming. That used to be my favorite thing, but now, I can't do that. So I play a lot of video games. I always have, especially since going into the wheelchair. And honestly, none of my friends are ever bothered by it. People actually don't care as much as you'd think.
Right.
Well, unless, you have the wrong friends, but if people are treating you like that, you just get rid of them. Don't keep those friends because they're not really.
They're not your friends, right?
Yeah.
They're
The only
not really
frustrating thing
friends.
about school, though, is all the time people are like, man, I wish I was in a wheelchair. Of course, I'm sitting there like, no, you don't. It's a living nightmare.
Yeah. Yeah.
But, I didn't say that. But I was slightly judging them, probably. Like, you don't even know me.
They always think it's fun to go fast, maybe.
Yeah. But these things are harder to drive than you think, too. A lot of people have tried to sit in them and go, I can't even drive this. I'm like, really? It's not even that hard. But I play video games and stuff all the time, so me driving isn't even a question of whether or not I can.
Right. So you said you're a video gamer.
Yep.
What's your favorite game?
Well, right now it has to be Fortnite.
On what system?
I have an Xbox Series X.
Okay.
It looks like a mini fridge, though. They even made an actual mini fridge that looks like it because of it. They
Wow.
took a joke and went with it and went real product.
Well, with that, gaming being an important part of your life, has you changed the way you game and the way you use your controller or anything like that?
Yeah, because over time, everything weakens, including your hands. So, how you hold the remote's completely different. But I've learned to adapt, and I know a couple products that technically they made not necessarily with adaptation as one of its purposes, but turns out they made some things that, it's like Microsoft has an official, adaptive controller for many different things. But for my condition, you do have to buy a more expensive controller, but unintentional side effects of its design make for accessibility for it.
Right. So something that wasn't really made to help people is ultimately helping people.
It absolutely does, I think. Not a lot of people know about it, I think, but I feel like maybe if they knew about it, they could advertise it as a intended function of that controller.
Well, it sounds like you need to get on Twitter or somewhere and let them know
Well, I mean,
how it's helping people.
yeah, I don't know how to get in contact with that kind of stuff yet.
I think Twitter and online, that's probably the quickest way to get in touch with people sometime.
You gotta know people a lot,
TikTok,
though.
make a video.
Ooh,
Well,
I
you
don't know
know
about
people,
that.
but sometimes it's just knowing one right person or getting enough people behind you.
I haven't found that person yet, then.
Yeah.
I'll let you know when I find them.
Keep working on it, yeah.
There's Anthony on one of the Jett sites. Is that
Anthony,
the
he's an
right name?
ambassador. Yeah.
Oh, I could, be like, hey, I got an idea.
And he's a fierce advocate, I will say.
That's good.
Yes.
So good to
I'll
know.
introduce you.
And so with that, remind me, how old are you now?
21.
So 21, you're out of school.
Yeah, mind you, my doctors, when I first got diagnosed, thought I was going to die before graduation. Which, at that point, not going to lie, that probably was true. But obviously, there's so much research done that even in a year, it's like, oh, never mind. Plus, my goal is to prove doctors wrong. It's fun.
Yeah.
It's
We like this kind of proof.
It's like, hey, you said I was going to be dead. Who's laughing now? Well, obviously, they're not laughing. They're probably really happy, but, it's still fun.
So you made the comment that, doctors thought that you might die earlier. When did you find out in that age coming up that was the seriousness of your condition and their thoughts towards it?
Well, honestly, I never thought of it as anything too bad. If you're going to deal with it, what else are you going to do?
That's true.
I guess, probably those teenage years is when you start having anxiety about, like a lot of people do even without disabilities, what is going to happen when I die? Am I going to die? Like, all that stuff that comes with middle school, brain development. But not really afraid of it.
Okay.
In my opinion, death don't come till I say it does. And it ain't anytime soon.
Good.
Got too many video games that haven't come out yet,
Yep. I'll just keep on planning.
Yep.
Now, with that, with your transition out of school, because you're out of school now, what are you doing and looking forward towards the future?
Not college. Turns out not everybody's destined for school. And, because of my shorter life expectancy, I'd rather, make a difference as an advocate, but also just have fun and not grow up.
Yeah.
I like to think I'm an adult that's still a kid. Well, I am. I can talk like an adult, but I act like a kid more. That's okay, though. I guess right now where I'm at, I go to a day program, 4 days a week. And, surrounded by individuals with different cognitive and physical disabilities.
And so what do you do in your day program?
Well, we hang out and do lots of stuff with the staff that we want, with a few guidelines. And then we go out, like, on field trips, or sometimes we have what they call personal shopping, where, we can go shopping. And then I work on Saturdays and Sundays at Walmart.
And what kind of work do you do at Walmart?
I'm just a greeter in the greenhouse and the lawn and garden at my local Walmart.
Okay.
I can also help with miscellaneous tasks if they ever need it. But right now, I'm thinking about maybe pursuing a different job at a local, like, Lego store we have.
Okay. How did you end up deciding that you wanted to do work?
Well, my parents always said, you want to buy dumb stuff, get a job.
Okay.
So, what do you think I did? I got a job and said, look, I'm being responsible and giving the government money, but also, you said I can't buy this video game? I just did.
Yeah.
And my dad's like, always telling my mom, he can buy that. It is his money. So, me, after a bunch of Fortnite purchases later, I probably shouldn't have done. Oh, well. It's my money to spend.
So how do you think having a job fits into your independence or your independent lifestyle?
Well, it proves that I'm not useless. And, even though it's gotten better over the years and people really do not really mind people with disabilities anymore. In fact, I think it's a sign of respect, like when those young kids just stare at you like you're the weirdest thing. I love that. I'm like, what's up? And they're like, what are you? It doesn't bother me, though, because they need to be educated. So, if you're a parent with a young kid, don't shoo them away from us. We're not to be feared. In fact, more often than not, we're happy to tell your kid what's wrong with us in a way they can understand. Or, I don't mind if they think I'm weird. They're young. It's not wrong to be curious.
Right,
And
and you talk about advocacy too.
Yes.
And how important that is into your life. And I think advocacy also includes education of the population outside
Right.
of who have your disease.
Well, my mom did something like that when I was in elementary school by educating some of the classes on kind of the bare bones of the condition. And like MDA used to do the fill the boot. She would educate people on stuff like that. And ever since then, the people that remembered that, it got spread through the school. And everyone thought I was, honestly, even though I didn't think I was that well known throughout the school, a lot more people knew my name than I thought. So obviously I made a name for myself. I didn't even realize it. But that's also part of being a Canter. We're just cool like that.
So did that affect your friendships? Do you feel like you met different people because they were in some ways more accepting of your disability, or?
Yeah, you just meet people over time that you realize could care less what's wrong with you as long as you can do stuff with them. Turns out, everyone's a lot more relatable than you think, even if they're more capable. I met some cool people over my time. I started a video game club in high school. I met a couple people there. They learned a few things.
Okay. And so when we talk about kind of how your mom helped educate your schoolmates in school and how that helped you, if you could go out and talk to the global community up front and find a way to tell them what's most important to you, what would you tell them? What's the one or two things that are most important?
Well, everybody okay. So everyone, honestly, in some way, even if you don't think so, probably has something wrong with them, I'm gonna be honest. So everybody has issues. So you gotta think about the fact that we're really all the same, even those of us in wheelchairs. I don't know, I guess, the most important thing is honestly the people you meet along your path, or in my case, road, because I'm always driving. But I've met a lot of people, and you get to realize that being human is way more complicated, and you'll never really know all the answers. So the last thing you should be doing is questioning disabilities in that way too.
Sure.
We can all contribute, but like how schools teach everyone has to be treated equal. That's true to an extent, but when I was in school, different students had to be, approached in an individual way. So even with disabilities, we're not getting special treatment. We don't really like that, but you kind of have to give each individual special treatment based on who they are. Medical care does kind of work like that. Mm-hmm. And I think more people need to realize that special approaches for individual people is okay, and it's sometimes, during certain circumstances, okay to treat people differently, if you will.
To get to the same.
Yeah, in order to be, in order to be the same as the other kids, even in school, it's like, you have to treat each individual like they're unique, because that's just how it is. It's not that I'm more special than somebody, if that makes sense.
So tell me a little bit about what your day-to-day life is. What things you need help with, what things...
Well, obviously you need help getting dressed. And then I guess after that I gotta get comfortable in my wheelchair. So on most days you're looking at 20 to 30 minutes to get up total. Sometimes, it gets to be less as your caregivers get more efficient. Of course, getting those is hard as it is.
So, tell me, who's your current caregivers now, and what's been that process of
I have my
getting help?
Nurse of 6 years. We've had a night nurse for 2. I think about that. He's definitely unique. And then we just got 2 of the craziest women I think I've ever met. Stephanie and then her sister Tiffany. and they're both crazy. Take that as you will.
So, we know that sometimes finding, like you mentioned, finding caregivers can be a difficult task. How did you go about looking for these individuals now that you have a variety of different people?
Well, it gets complicated because we used to have a nursing agency, but honestly, I'm coming to realize I think, early on, I do think people need to, especially Duchenne, self-directed, honestly, is the better way to go. I personally feel after having it, because, you get to know people better when you do recruit them because the individual getting it's technically the boss. So I have a little more control over, like, my staff, I guess.
So when you're describing kind of two models of getting caregivers, there's the agency driven, so the agency finds people, hires them,
Right.
does their background check, right?
They have to follow very specific rules, though.
Right.
And as a nurse or caregiver, you quickly learn that's not going to work. It's not a black and white job at all. So some of those rules are ridiculous.
Mm-hmm.
They've, become part of your family. They're going to. It's just the way it is. So self-directed, you can integrate them into your family however you see fit. And, you can cook them food. And there's no rules, like, basically. If I tell Stephanie, hey, I want to take the dogs to a dog park or something, we're doing it. With the nursing agency, they're not even allowed to drive you places.
Right.
And a lot of kids with Duchenne don't have the limitations as far as, like, getting out when they have what they need. We want to get out and go wherever we want. But with the nursing agency, you're never going to get to do that. Then, of course, when you get old enough with my waiver, they gave us an ultimatum. They're like, you lose the day program, you lose everything, or you keep your nursing staff.
Mm-hmm.
Self-directed's the way out. So the earlier on you can get it, honestly, the better. It just lets you get more personalized staff. And so it is complicated to set up, but well worth it.
Okay.
Um,
Tell me a little bit about some of the equipment you use at home and even now.
Well, let's see, you got a cough assist, a vest, and then I have a nebulizer, most of which, the nebulizer I only use when I'm sick, but I do the vest pretty regularly. Well, we don't have a Hoyer lift, it's called a Maxi Move. It's better.
Can you explain why?
So I don't know if you know this about a Hoyer lift, but if you've ever been in one, it kind of bunches you up into a human ball. When you have a spinal fusion surgery, I think most people, some Duchenne patients probably have a higher pain tolerance, but the thing bends you like a macaroni noodle.
Yeah.
You're not flexible when you have titanium on your spine. You don't bend. It was extremely painful. In fact, that's the first time I ever dropped an F-bomb in front of my parents. Because I did. The pain was so immense. The only way I could indicate it, because they weren't listening otherwise, was to just let out an audible bomb like that. And they're like, oh, he wasn't kidding when he said put me back down.
Yeah.
So I was stuck in bed for 3 days. Well, my dad and my grandpa had to go get it from a hospital that was selling a used one because someone bought it like when it was closing down. I think Maxi Moves are probably the better way to go, and doctors should probably advocate more for getting one of those if they can.
So what does it look like or feel like for you?
Well, it honestly feels like you're just sitting up. You can lower it back or up or move it up and down. It's very comfortable. It really is. They make an all-day sling you can sit on top of. Just taking it out is hard. It's good. It's what I would recommend because it's not as weird as a Hoyer lift, and it is electrical. Because let's be honest, we live in a world with technological advancements. Why not try to provide more people with that? Because what's frustrating is, a lot of those things they use in homes and stuff aren't electric.
Right.
I don't think that's just, I don't know. We shouldn't have to rely on old stuff. But, there's nothing wrong with technological innovation.
So tell me about your wheels that you have here. How important are these wheels for you, and how comfortable did you make this?
Well, absolutely, you need a power chair. People with muscular dystrophy, we don't have the strength to manual a wheelchair. And it was hard to get, though. You're always going to be arguing with insurance about these things. I'm sure a lot of you probably know that, though. My mom has had to deal with a lot because of that. So thanks, Mom. Shout out to my mom. But yeah, it's very, you can get it adjusted. It's probably a good idea though with your like wheelchair adjustment people to have a technician you really trust and get to know well. Local is the best to go with for sure. You know, it can do all sorts of things. It's adjustable. You can put your legs up. You can lay the backrest back or the whole thing.
Do you have seat elevation on your chair?
Yeah. So actually, insurance now, if they cover a wheelchair, well, that just comes covered with it now. So, you know, you can go up higher if you need. So they cover that stuff more,
Okay.
which is really good.
All right. So let's talk a little bit about your home situation and all the equipment and things that you use there to kind of help maintain your independence as you go through these things. I wanted to talk a little bit about your experiences dealing with physicians and in the clinic, right?
Uh-huh.
So you see Dr. Emerson and the Peds MDA clinic, is that right? Tell me, what is it like coming to a multidisciplinary clinic like that?
Well, that's kind of what I was speaking to way earlier is we don't have that in Springfield, and I hate that. Yeah, but, you know, I'm glad to come here, and even if they were to add that to Springfield finally, I think I'd still continue coming up here. Because even if they were to get something real good in place, it would still take a while to develop. And, you know, once you get to know a physician long enough, you really should stay with them. And I think it's been long enough. They know, and we can shoot them an email if we ever need anything, and they're immediately like, we'll get you what you need. Dr. Emerson's pretty cool. I really like Dr. Emerson. She makes the trip worth it. Well, all of them do. They all just seem to care. Like, they individually want to help the patients. Like, they're there to help you. You know, they're not doing it for fame or money at the end of the day. They got the job because they genuinely care about their patients. And that alone makes a difference in the clinic because it almost feels like a doctor family, I guess, almost. If that makes sense.
It does. So you're okay. Well, it's nice when you're in clinic to be able to see different specialties all at one time. So
Right. Yeah, that makes it definitely good. And, you know, for, like Dr. Nur was saying, you gotta have different doctors for each individual, like, part of the disability to really get the best care. Plus, you know, they're doctors that'll listen to you. Now, first and foremost, listen to me before, you know, don't get me wrong, my mom, you know, is important, and they'll listen to her too, but they really do try to make an emphasis on, at the end of the day, I'm the one driving the wheelchair. So I have to steer the ship, you know. And I take into account what the doctors say, of course, but it is nice that they're willing to compromise even. Because it's not black and white, and they get that.
So tell us a little bit about kind of your treatment journey since you've been in that clinic.
Well, we haven't had any issues of mean doctors. We've had a couple of those over the years. But everyone at, combined clinic, I don't know, I think we started going in, well, we were going whenever it was not, well, we got sent to peds after, I don't know, it's kind of complicated. But, everything I've gotten has always been effective in what I needed.
Sure. What about medication treatments or interaction with therapists? Have you, so oftentimes in the multidisciplinary clinic, you have your different therapists that come through and offer suggestions about different things. How have you been able to interact with them and make adjustments in your life based on maybe some of their decisions or suggestions?
Well, you know, some of my machinery, like we needed an upgraded cough assist. We got that, but we, needed help and stuff. Plus, like the testing you get is important. You know, as much as I don't like it, I'm still gonna do it. And I've always thought you can hate something and still do it. You know, some people are like, why are you complaining? Like, you just have to do it. I can complain, you're still getting what you wanted, right? But yeah, I have no issues with that. All positive things have happened, I guess.
I have a quick question. So in terms of transition, so we're talking about you're still at your pediatric clinic, right? Are you okay with that, or do you wish you were able to see more adult doctors?
Nah, because, well, the adult doctors you see, probably started out as a pediatric doctor anyways. They know what's best for Duchenne. They keep up on the research. We went to the so-called adult specialist for it in Springfield. They didn't even know that prednisone was still continued usage. They didn't update their education. I feel like pediatric doctors actually do. Like, pediatric doctors honestly probably better than half the adult doctors adults see. I hate to say it, but adult doctors are not adequate because they start at the adult level and it just doesn't work. So no, if they have no reason to move me, I hope they don't, because I'm getting what I need. And if that means an adult has to go to a pediatric doctor, oh well. Right, you get stickers and stuff if you ask. Even as an adult.
It's important.
Yeah, I get a little participation prize. Adults like those too, believe it or not.
They do.
So that's all. It's an interesting take for individuals who, because depending on where you are, that transition may happen at different ages, especially some of the more busier clinics, I would say, on the pediatric side of things. So it's good to hear your take on why you would say in pediatrics, and then why it might be different for somebody else who might have a disease that manifested itself a little bit later.
Yeah, Duchenne, definitely you need to keep up with who saw you probably for the longest, and that's usually pediatric doctors. But, I don't think Dr. Emerson or Dr. Nur have any intention to kick me off anytime soon. I hope. You better not.
So, and that also shows just the, for adult doctors, so I'm an adult neuromuscular physician, I think it shows the connection that individuals have when you have something for such a young age and you build with that community. It can be very difficult to make that transition into an adult field, because you're right, in adults, we don't have stickers. Not those kind of stickers.
Yeah, it's not as exciting.
It's not as colorful in the clinics.
Every time I go to an adult doctor, I'm like, where's my sticker?
Only thing we have in our clinic are lollipops.
You need to get a lollipop bowl then, I think.
Yeah, I think that would be it too.
You got to start it somewhere. Community lollipop bowl, yay.
So, my other question would be, oftentimes there are medications like the prednisone and things that you take in clinic. Have you ever had any negative interactions for any of your medications, or made some decisions to transition from one thing to another?
Well, so with prednisone, that's probably got some of the longest side effects that you can notice. Unfortunately, most of us with Duchenne, we look like the Michelin tire guy. But we didn't do that on purpose. It's the prednisone's fault. I don't want to be an automotive sales guy, but I am, I guess. But that shuts down a lot of stuff. Like, your adrenal gland just quits working. And even if you were to switch off of prednisone, I don't think that's ever coming back. You use it for so long, it destroys parts of your body function. So, now I need, like, testosterone gel because I don't produce it at all, because that's related to your adrenal gland, which, according to my endocrine doctors, doesn't work at all. The prednisone basically killed it. Which, prednisone, though, because I've been on it for so long, the worst part is I need it now. Like, my body's dependent on it, so you can't get rid of it either. Like, if you're sick and you can't take it, that's bad. You can get hospitalized simply because you can't get your prednisone in your system. So we have to have an emergency shank of the stuff. I'm thinking some of my main nurse is probably like, man, I hope I get to use that someday. And I'm like, no. But, so, that affects you the worst. And the heart meds, while necessary, because they slow the heart down to keep it alive longer, that's important to do. That can make you tired easily. Now that I'm on testosterone gel, though, that helps your energy. Because you don't realize how much energy that actually provides. So, there's a lot of stuff you need because of the prednisone, but it's also one of the reasons why so many of us live longer, I think. Continued usage of it is unfortunately important. There are some alternatives coming out that aren't steroids that do the same thing. So, if that works, get on that. But I'm on prednisone so long, unfortunately, I'm basically dependent on it.
Right.
if I went withdrawal from it, I think even if I were to switch off eventually, I don't know that that's even possible. And I'd rather not deal with consequences no one's really sure about. I don't even know if, how much the research is and what happens if you switch. I don't think there is.
So with that thought, and we think about kind of looking to the future, you know that there's a lot of research being done now and a lot of different opportunities that are coming, but research is slow and steady process,
and
right?
it unfortunately doesn't get to the non-ambulatory people anytime soon. Not that I'm discrediting any research, like it's all gonna get there someday. I don't think we'll see it in my lifetime. And, that's not to say it isn't possible, but science does take time.
So as we talk to our pharmaceutical companies and our drug development companies, and tell us, why do you think it's important that they include individuals who are non-ambulatory in their studies?
Well, I personally, I'm not like, I don't mean, not that I'm offended, but we do feel, a lot of us feel left out of the research field. Because it's like, what are you doing for the non-ambulatory people? And they're like, we ain't doing anything. I've unfortunately got that answer every time I've tried to ask. Because with the FDA, you've got to get it approved with young people first before they even think about adults. But even then, the studies have to be completely different. So, maybe the approach for that needs to change. I'm not sure how that works because I'm not a genius in that stuff. But I do think at least explaining why non-ambulatory might either take a while or maybe legitimately try to make something that's just for, like, legitimately get there, or try to, get the FDA to understand that, non-ambulatory stuff may not be the same, I guess. Again, I don't know how complicated it is, but it's not to discredit anything, but we feel left out. Because you see all these kids with the possibility of maintaining their dystrophin longer than you did, or, not ever being wheelchair bound, and it's like, what about us in the wheelchair? All I'm asking for is something that slows it down. That's all we need. And they're not here, but with PPMD, there was a guy I'm basically buddies with who is doing research on that, how to keep dystrophin lasting longer. And he knows a lot. They are only running it on younger people, though. And I'm not sure, I think it would work for non-ambulatory, but I don't think they've ever really tested it. The FDA doesn't really like stuff like that.
So if you could go to the FDA and have a magic wand and make them change some policy, what do you think you would ask them to do?
Well, maybe allow more testing on non-ambulatory people, obviously with our consent, because at that point they're doing trials that technically, there's not much data. Well, it's safe on mice and stuff, and then they move on to younger kids. But maybe run the same trial on non-ambulatory people, or a similar trial with the same thing, because the idea is the same. It would just be more maintaining for us non-ambulatory people. I don't think we're ever going to get walking back, and that's not what we're asking.
Yeah.
Just the dystrophin just needs to last longer, which again, that's one thing they're working on, but they haven't tested it ever on non-ambulatory, and they're not certain it even works because they can't. They have to meet the FDA's criteria before they'll go, oh, well, maybe adults could get tested. But it's a little more complicated since the adults with Duchenne are going to be non-ambulatory, because at that point, that's what happens.
Yep.
So
if you could find a drug now that would be able to maintain you right now where you were and had no further progression other than, the normal aging stuff that people get.
right, or way slower at least.
Mm-hmm.
Because, because there is one that kind of does that, but they haven't, like I said, non-ambulatory isn't in the visible future. And, it's mostly because the FDA needs enough data first before they even allow other studies like that. And, we have to give our permission to even participate in the study anyways. So if I'm willing to, possibly get killed or something, it's for the betterment of my own fellow, Duchenne people.
So with that same line of thought, where we're talking about studies and the risk associated with some of these new studies and new drugs that may be coming out, what do you think, or what would you consider, because each person is individual, your risk level? what would you be willing to accept?
Well, first of all, no one should ever be shamed for saying no to a study. If you don't want to risk dying like that, absolutely say no. But if the risk is relatively low or, not at all risk of death at least, unfortunately science is not without sacrifice. It never has been. But you'd be surprised what people are willing to do even knowing they could die just because they want to make someone else's life better in the future. Because the last thing I want is for future Duchenne boys to suffer the same way I have. We want better futures for those people. So, some people are willing to risk death. And you have to respect the fact that they know what they're doing. But you should also never shame them, of course, for not wanting to try. So the risk factor, really, it's up to the patient what they're willing to do. Because again, you always have to sign a consent form anyways. So if you want to say no, then say no.
So what do you think is the best way for maybe physicians or clinicians to approach individuals about research or research studies?
We'll bring it up, and honestly, if there's a study, just straight up ask them if they'd be interested, and if the doctor doesn't already have information on it, maybe look into it for the patient. Because, I think it's good as a doctor to be aware of what studies there are if you can. And definitely, what I want from my doctors, just don't lie, just up front. Is there a study? Can you help me understand what the risks might be? Because I do want to talk with my doctors about what studies I want to participate in, because they can help you with some guidance about it and, help explain some of it, really, I think. And I feel like talking to Dr. Emerson before just going, and signing into a study is probably a good idea. She's like everybody's doctor mom, pretty much. But, it's important that you just tell your patients, if you know about a study, just tell them. I mean, the worst they could say is, thanks, but no. Or, yeah, cool, can we look into that more? Because, the doctor needs to know if they should help look into it more or if they're not interested. And honesty goes a long way, even if it is kind of brutal news sometimes. I want it up front, though. That's how I want it. And that's how it needs to be, because sometimes there is no other way to sugarcoat it. And that's just the way it is. Like I said, I'm not afraid of death either, but, yeah.
So if you had to pick a piece of technology, so let's say more equipment, not necessarily on the drug design side of things, that would lead to a betterment of life or improvement of what you would, some of the function you might have, what type of equipment would you want to be made or
Ooh, well, I mean, obviously, the less equipment you can live with, the better. But, I mean, don't get me wrong, the vest and cough assist and stuff are all important. But, if there was a way to somehow just artificially, make fake lungs, I guess, that you could use. There's a lot of, cool cyberpunk type stuff that, shows that, a fake set of lungs that just works better and won't fatigue. I know that's probably not realistically possible, but it would be pretty cool to have a bionic set of lungs that fixes all the breathing problems. You never have to worry about pneumonia, because you can't get pneumonia in fake lungs that still provide you with air. I mean, it's always cool to imagine, but, there's nothing wrong with that, first of all, but you still have to accept reality at the end of the day. Being delusional as an MD person's not good either. But, what if is, people say what ifs are bad, but have a little fun with your life. Why not? Doesn't mean it's ever going to be real, but still cool.
what opportunities have you taken to connect with other individuals who may have MD?
Well, PPMD has a committee called PAC. That's really good. The PPMD conferences are always great to attend. You'll learn all sorts of great stuff. And then Dr. Emerson obviously brought me here today for you guys, which I'm glad I came. I like speaking about this kind of stuff. I think that's my purpose, really. Stuff like that. There's tons of options if you look. And of course, PPMD on their website has all the stuff that explains what PAC is and stuff. And anyone who's 18 or older can join because it's an adult-only committee. And sometimes, they speak to the younger Duchenne people and stuff like that. And anyone with who's younger than me that has Duchenne, probably needs to hear some words of wisdom, or just don't be, stubborn when it comes to this or that. Because, I fought a couple things, and as scary as it is, you can't fight all of it. Or you just have to embrace your reality sometimes to fear it the least. Like, when I had my spinal fusion surgery, that was tough. But I would tell any person with Duchenne, if I was ever, technically had to decide if I wanted it or not, if I could go back, I'd still make the decision every time to get it. The benefit you get is so much better. That's what I would say.
So, kind of in these last few minutes, I want to give you this opportunity to say, if you had one or two things that you wanted to tell the world about Duchenne's, tell your community and even your caregivers, anybody who's willing to listen, what would that thing be? What's the most important thing that you want to get out there?
Well, definitely more adaptive equipment, because it can be done, but maybe talk to the people in the wheelchair. We can tell you an idea, and then people who make concepts or whatever could totally do something like that. Also, we all need a robotic arm, because they're cool. And I think the other thing is, for sure, can insurance please just not question certain things? Like, there's like a cool robotic arm we learned about at PPMD, and insurance doesn't cover stuff like that because they don't understand. But like the freedom, even just that provides is crazy. We need people to listen to what kind of products we want. I think that's a big thing that needs to be heard. And things you make for muscular dystrophy work for other disabilities the same way too.
Absolutely.
If it works for one power chair, you can stick it on another one. We need more cool stuff like that. And I guess, the world needs to hear that we all need to, band together and fix insurance, because it's terrible. It's not what it should be for anybody with any disability. And I guess, I just think people need to be aware of what nefarious things certain companies are actually up to. So a lot of people who aren't in the wheelchair and don't deal with insurance like that don't know.
Right.
They need to know that they're not your friend like you think. Because, they deny it. They don't even ask questions. And even when they get the answer that says, why would you deny this? They're like, no. And there are grants and stuff, or you can do a GoFundMe for like something like a robotic arm, of course.
Yeah.
I still want one though. Because you can open doors and it can hold a can of soda. Like, just getting something back like that makes you feel more like you fit in, because I don't think I don't fit in, but sometimes, you just want to fit in more. And, they need to understand that mental stuff does help a lot with our life expectancy. So if you don't give us cool stuff, it doesn't always work out.
Right.
'Cause I could shake hands with that. Because I can't. People are like, what, do you shake hands with like fist bumps? Some people don't understand that, though. If I had a robotic arm, you stick that up, and they're like, whoa, and it's like even cooler.
Yeah.
I already got a metal spine. Why not add an arm on it? And, well, you can feed yourself with it, too.
Yeah.
And it's all controlled with your wheelchair.
So it offers a different level of independence, for beings. So
I think stuff like that maybe it just needs to be, more readily available, and shame on the government for not making it allowed to be sold cheaper.
Right.
And I know that stuff costs lots of money, but I think there needs to be a way to get it in an easier way if you really do need it.
Yeah.
They don't make that easy.
Absolutely.
I know it's technically a want, but I mean, it does create some opportunities for jobs, though.
Yeah.
Can't do a job, you get a robotic arm, though, and they'll hire you. Why not?
Yeah. So I'd like to thank you for taking this time to talk to us and give us a little bit insight into your life and your thoughts and process of living with this disease, because it's very important to hear from the individuals that have it,
Right.
and how it impacts their life. So I just thank you for taking this time to talk to me today and then talk to our group.
Yeah, you're welcome.
And thank you for being here. All right, and with that.